Good morning, sir. These are the exercises done in Unit 3. 65-year-old male with closed middle distal third sharp fracture of left femur. So, Winkiston Hansen type 2. Do ORF with plating.
What about patella?
Patella is operated 12 years back, sir, outside.
How many years back?
12 years back.
12 years back.
Yeah. Yes, sir. Yes, sir. Outside, sir. No, yes, sir. Movements are normal, sir. Yes, sir. We counsel, sir. We counsel the patient, but we counsel the patient, sir.
When to remove the implants, especially
We-
for adults, patellar fractures?
2-3 years, sir.
8 months to 1 year. 8 months to 1 year. There is a big chart is there in Campbell for adults.
Yes,
It is given only for adults. It is not given for children. That is also important. Children and adults implant removal varies. Yes. Go back. Go back to the first slide. So what type of fracture is this? You said Winkist Hansen's.
Type
What
2.
is AO diaphyseal classification?
So,
Is there or not? AO
Yes, sir.
diaphyseal fracture classification. No or don't know?
yes, sir.
No, don't know. So type 1 is only transverse or oblique fractures, simple fractures.
Yes,
Type
sir.
2 is a wedge fractures. Type 3 is comminuted. Is there a wedge or no wedge?
Wait, sir.
It's a spiral or it looks like a wedge fracture.
It's a spiral, sir.
There is a fragment, is there? No fragment? Huh? There or not there?
Yes, sir. It's
Okay, right.
fragment.
Go ahead. That is AO. Now Winkist on depending upon the column, medial column, lateral, 50%, less than 50%. That
Yes,
is
sir.
all. 3 column intact, 4 column intact, medial cortex, lateral cortex, anterior cortex, posterior cortex.
But in lateral, there is a fairly wide gap. Chance of union are very poor. And if it doesn't show any signs of union, the plate invariably breaks. Over
First we tried MIPO, sir, but first we tried MIPO, but reduction is not.
very unlikely to use.
65, sir. 30-year-old male with subtrochanteric fracture of right femur. Sir,
Supposing in case it doesn't show signs of union, even at the end of 8 weeks, no sign of callus at all.
sir.
How do you proceed? This is the likely scenario. Why a nail was not preferred?
Fracture.
There is fairly a long segment,
Yes.
Yes, sir.
though there is a small longitudinal splinter, still it can be locked. Quite positive. I think there is a splinter there. The APG, you find a what? On the medial
Sir.
cortex.
Sir, sir.
Here, good. Here you can see a long
Yes, sir.
linear here it is extending right from the comminution is extending
Yes,
right,
sir.
of course. It is a choice, but reduction.
Yes. For discussion sake, these cases, some people are going with the DFN, distal femoral nail, but you should go up to the level of lesser trochanter. If it's short of lesser trochanter, there is high chances of rotational control and high chances of stress riser effect and refractures. That is also described. So, PFN versus DFN. That is also, yes sir, go ahead.
30-year-old male with subtrochanteric fracture of right femur. Sir, Russell Taylor type 1, sir. We do CRF with PFN for right femur.
What PFN?
Sir,
Long PFN.
long PFN.
So this. For long PFN, you got right and left.
Yes, sir.
Short PFN?
No.
No. You have taken washers also. What is advantage of washers?
To
What are the advantages of washers?
to hold the contact between screw and
Ah,
It prevents inward migration of the screws.
proximal migration, and it gives better stability, better compression, better stability, and removal also is better with the washer. Without washer.
Next.
Yes. What?
30-year-old female with a closed distal third both bone fracture of right leg. I do CRF with island for right tibia, sir.
This is an ideal case for cermientoplasty. There is only a little angulation, hardly 15 degrees of angulation. Only in A to U. Here, the periosteum might have been intact on this side.
Yes.
Fracture hematoma, closed healing. Very long purchase in the proximal fracture for the cermientoplasty. But we don't. Ortho.
Mm, yes, sir.
It's a transverse fracture almost. Okay, go back. It's a transverse fracture. Mostly transverse,
Yes, sir.
little oblique, and the medial cortex is intact in the sense continuity will be maintained. It's a very stable fracture. With cermiento, probably you could have made him bare weight at the end of 3 weeks. Yes. Early vein bearing is feasible with this cermiento rather than the nailing.
It is a both bone fracture or single fracture?
Both bones, sir.
Both bone.
In any tibial fractures, operate. What are the advantages? You should tell the advantages. When a question has been put, young man, early mobilization,
Yes, sir.
joint stiffness can be prevented,
Prevented.
disuse osteoporosis can be prevented, can get back to his
Daily activity.
not daily activities,
Oh.
his earning capacity
Okay.
sooner.
Yes, sir.
Remains also same, at least. You
Yes,
should
sir.
try to defend yourself, the advantages of the surgery, rather than keeping quiet.
So you have to talk about 3 points. Closed methods, plate, nail. Revisions, that is different. Where you get revisions? Orthoplasty.
Yes, sir.
Here you are going redo procedures. So you should have got the clear clarity concepts, everything. क्या विशाल समझते ना?
Yes,
हाँ
sir.
समझो.
Next.
31-year-old male with a closed middle third shaft fracture of left femur. So, vein kissed Hansen type 1, sir.
What do you mean by type 1?
Mild combination, sir.
Mild. How much contact is here? Articular. So bone contact? Less than 30%, more than 30%.
Less, more than 50%.
How much contact here? Wing
Less
kissed
than
Hansen.
50%.
Huh?
Sir, transfer fracture.
That's why you have to use now AVO class diaphysial. AVO, simple transverse or simple oblique or simple spiral. Then wedge fracture. Then last one is complex fractures. Complex or segmental fracture. There is a difficult, comminuted. Complex may be comminuted, complex may be segmental. So that is about diaphyseal classifications.
Yes,
Yes,
sir.
sir. Go ahead.
We do CRF with island for a left femur. Yes, sir. Yes, sir.
Good bone stock,
Yes, sir.
hanging bone, middle third, long purchase in the distal fragment as well as the proximal fragment.
సార్ మొన్న
Touch down
సార్
pelvic socket.
యా కానీ ఇది అయిపోయిన తర్వాత చెప్తాను సార్ వెరీ రీసెంట్లీ సార్ వెరీ రీసెంట్లీ ది ఇన్ఫెక్షన్ డెట్ గాన్ ది జిఓఈ వెరీ రీసెంట్లీ దే సెట్ ఫర్ ఏసీఎల్ వన్స్ యూ టేక్ అవుట్ ద ఏసీఎల్ అవుట్ ఆఫ్ దట్ ఇట్ షుడ్ నీడ్ సమ్ antibiotic coverage sheath because it is out of the parent. So there are high chance of infection rate. So it should be covered with some of the antibiotic material. So in the what about bone graft? Bone graft also same. When you take out the bone from the parent, you are putting in some other place. It is also something different. So everywhere you put antibiotic. So that is a school of thought. So that point should be taken. And then anitlo some of the people are doing directly primary bone grafting. So earlier people used to say masculine technique is post-op procedure. Earlier people says masculine is a post-op. No, 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 not this is sir. General, నేను చెప్పిన పాయింట్ చెప్తాను. Yeah, ఇక్కడ కాదు.
Regarding that, when
Yes.
occasion arises,
Yes,
otherwise a lot of confusion will be there.
yes sir.
Otherwise they will put bone graft to this.
No. Yes sir.
If there is a significant comminution with involving more than 1/3 of the circumference, they are unlikely to heal, especially with open reduction.
Yes, sir.
Scenario is different with closed reduction. That is a standard textbook description. More than 1/3 circumference comminution, primary bone grafting was indicated.
Yes, sir. 35-year-old male with a base of first metacarpal fracture of left hand. It's a Bennett fracture, sir. We do percutaneous pinning fixation for
Can't you treat it conservatively?
chances of
Can you
subluxation.
treat or can't treat?
We can treat, sir, but
How? Suppose you don't have the facility to operate.
Hmm.
No CM, no surgical facility. You are a conservative orthopedic surgeon. How, how are you going to treat it? And before that, why it is necessary or essential to operate? First examine. Why it should be operated? It
So-
is an indication, no doubt about that.
yes, sir.
Why it is
Axial force on the axial force with partially flex metacarpal.
what are the deforming forces for this fracture?
Deforming
Thanks.
forces.
Abduct. Yes, sir.
There are two deforming forces opposing. Whenever there are two deforming forces, it will be very, very unstable.
Yes, sir.
The abductor pollicis
Longus.
longus tendon gets inserted here
Yes, sir.
to the base of the first metacarpal. It tries to pull it proximally, and the adductor pollicis gets inserted into the neck of the first metacarpal. So this fragment gets adducted, see, ulnar deviation, and it gets pulled proximally.
Yes, sir.
So it's very, very unstable. That is why to neutralize the both dynamic deforming forces, you will have to stabilize it.
Yes, sir.
It can also be treated conservatively,
Right.
provided you know how to do it.
Yes,
So
sir.
reduce the fracture to as anatomic reduction as possible. How to do that?
Yes, sir.
How to reduce?
First, give the longitudinal.
Show it to the audience. Fraction.
Yes, sir. Longitudinal traction. Keep the thumb in pronation and give the
Thumb cannot be pronated or supinated.
gentle traction
So
over the base of
traction-
the first metacarpal.
Traction is going to reduce the proximal migration. how erection can be undone. Adductor policies.
To place the first base of first metatarsal.
So you have to push this towards the
Yes, sir.
small triangular fragment here. You have to push it and then keep it widely abducted.
Yes, sir.
The thumb should be widely abducted.
And mold properly, right?
And you should reinforce the plaster with extra thickness and hold it until it gets set. And there should not be any gap left between the skin and the plaster. Preferably you should put a stockinette or a one layer of soft rubber,
Yes, sir.
not more than that.
You want to stock in it?
Soft.
You see what stock in it?
Just like your socks, stop to stop like that. You know socks?
Yes, sir.
You got a sock, show me your socks. Show me your socks.
Few years back, I have treated a young lady with Bennett fracture of this magnitude, and she was very reluctant to get operated. I treated with plaster. The function is normal.
Yes, sir.
Okay, and in the candle, I think he describes that if you apply the plaster effectively, at the end of the plaster removal, you will find a small area epidermal necrosis producing a small hypopigmented patch. That much is the pressure that it needs to be applied to the plaster molding. It is very clearly described in candle. There is a hypopigmented area of epidermal necrosis.
Just put a cast in
That is the observation made by
You have to
the
mold
stalwarts. He has described it in the textbook. Yes. Some people are reluctant to get operated because they see in the X-ray there is a very small fracture. They don't know the importance of it.
Yes, sir.
So you have to impress upon the patient the need for operation. Otherwise, they are going to land up in future carpometacarpal arthrodesis. That is the only alternative if they develop CMC joint.
What complications there for bone surgery?
Sir.
What complications you get? You don't do surgery.
So
Fracture getting displaced. What
yes.
is the patient can have some tablets and then subsides. What else is there?
Restricted movement, sir. Movement is restricted. Thumb.
Why? Osteoarthritis early.
Yes, sir.
Post-traumatic arthritis
Functional thumb is
of
lost.
CMC joint.
Yes, sir.
Thumb is the most important for fingers. Okay. This is an anatomic reduction is the main report. And if you still find it is unstable, you can pass another K-wire between the shaft of the first and the second metacarpal.
Yes, sir.
If you feel that it is not that stable. In fact, you can push it a little further also. This is too small purchase. See here,
Yes, sir.
very little purchase here.
What type of joint is typical metacarpal joint? What type of joint is typical metacarpal joints?
Do you know how many types of joints are there in this classification? Then you will be able to.
No,
Does
sir.
it have maximum movements or not?
Huh, sir.
Does it have maximum movements in this joint?
Yes, sir.
So what type of joint?
CMC, first
Saddle tail.
Yes, sir.
So maximum movement you have saddle. Saddle, first is joint.
Saddle
So
type.
maximum movement. You can get a first osteoarthritis on this joint.
And more common in females, the two housewives
Yes,
who
sir.
are who will be indulging in lot of day-to-day activities in kitchen.
Yes, sir.
Next.
Oh, sir.
When you are going to assist or operate on such cases, especially during PG, you should read about it and go. The case could have been posted one day before.
Yes, sir.
Have you read regarding that? Who has assisted this case?
I'm not for this.
Who has assisted? Who has assisted? First year. Make make it a habit to read about the surgical exercise. You know the list already one day before. So you have to read the surgical approaches and about that in detail about that particular procedure. Whether it is a fracture or something else.
Good morning, sir. These are cases done in Unit 1, sir. 70 years male with intertrochanter fracture of left femur, sir. Biden Griffin type 1, sir. Stable fracture. Stable, sir. Close reduction in internal fixation with short PFM, sir.
What is this? Where a fracture?
Yes, no, sir. Screw missing. Screw missing, sir. Distal screw.
The mill hole didn't match.
Yes, sir.
If you try to put multiple drill holes, the screw is never going to hold it.
Yes, sir. Yes, sir.
That is ideal for this case. In fact, it appears to be more a basal type rather than intertrochanter. Lesser trochanter hole, lesser trochanter is intact. Yes.
A 27-year-old male with 20 days old compound grade 2 middle third shaft fracture of right tibia, sir. We have done a close reduction internal fixation with it. Yes, sir. Yes, sir. We have put debridement we have done, sir.
Was the bone exposed that way? Removing it with scab.
Yes, sir.
20 days.
20 days old.
Obviously, some looks like some skin loss is there. Because the scab appears to be really thick.
Just debride it and put an ILN, sir. If possible, we can do a split thickness skin grafting, sir. But no, sir. Not exposed, sir.
It is on the shin. There is no muscle over there. Just under the skin, you get the bone.
Either we can debride and leave it as it is. It will heal by itself.
Yeah, this is another ideal case for conservative management. More so in presence of a wound. Anatomically reduced, no displacement, fibula intact. Generally, it may not get displaced further. If it doesn't unite in subsequently after 2-3 months, then it is a different matter. It is likely to heal.
You want to do what? Skin grafting? When you want to skin grafting? The more is exposed. Wait till the dilation is comes up. Is that is done to turn direct on the bone. Or flat can be done.
Yes.
In other case, wait till the dilation comes up. Then you can go for a skin grafting. Meanwhile, it may happen.
So, perioperatively, is there any discharge correlated to serious?
No, sir.
Sterile.
Sterile, sir.
Parameters are normal.
Normal.
CRP, everything is normal.
Yes, sir, and is slightly elevated, sir.
Slightly. 30, 40, 50, 100,
50, sir.
50. The wound is connected to the bone.
Yes, sir.
What
80.
is the grade of compound? Grade 1, grade 2?
Grade 2, sir. Grade 2, sir.
Sterile wound,
Yes.
not contaminated.
Yes, sir.
ODA classification.
Yes.
What is the importance of ODA classification compared to Reslow-Sanderson classification? What is the importance of OTA classification, Orthopedic Trauma Association, versus Gustello
Don't know,
What's
sir.
the difference? So they talk about more of bone loss and also they talk about neurovascular comfort. The most important contamination. 2010 and 2006 and 2008, there is one more classification by Rajshekharan and team from Ganga Hospital. 2006, 2008 is also presented in Campbell only for grade 3A, 3B component. Only for TBR, not for femur. That is Ganga Hospital score. Here also they talk about the soft tissue coverage, bone loss, contamination.
Next.
85-year-old female with intertrochanteric fracture of left femur, sir. We have done close reduction internal fixation with PFN, sir.
Go back to this X-ray. Any of our PGs are going and taking the X-ray in this position, or the radiographer has made it a habit to
The pelvis with both hips is a traction X-ray, sir. So PGs will go, sir.
somebody is following the
Yes, sir.
Sure.
Sure, sir.
protocol.
A 29-year-old male with intertrochanteric fracture of right femur, sir. We have done close reduction internal fixation with PFN, sir.
What is the mechanism of injury? Direct injury, indirect injury.
Slip and fall.
What type of mechanism of injury? Mechanism of injury ఏంటి? Direct injury, indirect injury?
Indirect only, sir.
Indirect. So intertrochanteric fracture more common in indirect injury.
Yes.
Huh? Lakshmi Prasad? Lakshmi come. Lakshmi come. Again also. 29 years.
It requires a significant violence. Just by slipping and falling, it doesn't happen. It requires considerable force to break it. See, the quality of the bone is so good. Young man, 29. Next.
సింపుల్ ఉండగానే గొళ్ళని పడతాయి. జాగ్రత్తగా ఉండాలి.
ఉన్నావు కదా నువ్వు గొళ్ళాలు తీయటానికి.
A 23-year-old male with closed middle third shaft fracture of right femur. We have done close reduction internal fixation with interlocking nails, sir. This is a 10 months old male baby with closed middle third shaft fracture of left.
So you are operated immediately 1 or 2, 3 days. In how many days this case has been operated?
2 days.
2 days.
Yes.
So there is no soft tissue interposition.
No, sir.
Huh?
It was there, sir.
There. So you are opened the fracture. అంతే కదా soft tissue interposition.
Close reduction, sir.
అదే soft tissue interposition అంటున్నావు. And you are done a close reduction అంటున్నావు. Huh?
లేదు సార్ లేదు సార్
ఆయన ఉందన్నాడు అందుకని.
లేదు సార్ కన్ఫ్యూజ్ అయినా
జాగ్రత్త ఉంది. ఈ కేసు these are the femur. You should be very careful, especially these type of fractures.
This is a 10 months old male baby with closed middle third shaft fracture of left femur, sir. We have put an hip spica, sir.
Infants.
Gallows traction we can put, sir. Because the weight when we lift the it will reduce the fracture, sir. Why didn't it requires special beds, sir, which are not available in our ward, sir.
And the patient needs hospitalization
Yes, sir.
at least for 3 weeks.
Yes, sir.
Two disadvantages
Yes, sir.
and complications of gallows traction.
Yes, sir. Femoral nerve palsy.
Vascular and neurovascular both.
Sir? No, sir. It will correct. No, sir.
whatever the position is the model itself, the good position. Advise them not to take any X-ray at all. That's what counsel me done. Right.
Even 30 degrees angulation, the bone gets straightened for a period of an year or two. Great remodeling capacity.
And other is pediatric trauma split. That's also there.
Okay.
Yes, there. Pediatric trauma is there. It's also one simple pediatric trauma split with fixed traction.
There is no fixed Thomas splint for anybody. It is customized to the individual.
Fixed traction.
Someone advised tens of this corporate setup.
I do available.
5 years old male baby with closed supracondylar fracture of right humerus. Garland classification type 3, sir. We have done open reduction, internal fixation with K-wire, sir.
This is a 75-year-old female with intertrochanteric fracture of left femur, sir. This is Boyden Griffith type 4 with a subtrochanteric type 4, sir. Subtrochanteric extension is there, sir. So these are the intraoperative pictures, sir. Yes, sir. ORI, sir. Only one, sir. One, sir. Yes.
Rate augmentation.
Yes. We have done ORIF with long PFN, sir. A 25-year-old male patient with 1 year post-op follow-up case of closed middle third shaft fracture of right clavicle with implant in situ. That is a plate, sir. We have done implant removal, sir. No, sir. No, it's intact, sir.
Fracture united.
Fracture united, sir. No, sir.
That's how it's a contoured AO plate or what type of plate is this?
Normal DCP only.
3.5 or 4.5?
3.5, I think, sir.
Contoured.
Yes, sir.
With circulars wire.
When was it done?
Interfragment screw also is there. Interfragment screw also is there.
Yes, sir.
When was it done?
1 year back, sir. Yes, sir.
Why has done? For removal or
Because of the hardware problem, sir. The plate was impinging, exposed on skin.
what about the complications of this?
Yes, sir.
Wire also is there that will come out from the skin.
Yes.
Blade on the skin comes out with wound there. So that really is very careful operating this.
Yes.
Doing surgery for class is very easy.
Yes.
But complications are too many.
Yes.
This case we are required here.
Now they are getting contoured AO plates also. Yes, sir. AO plates also.
10 years male child with
Implant removal.
yes, sir.
Okay. Next.
Tens removal. 59 years female with closed middle third both bone fracture of left forearm, sir. We have done open reduction with plating for both radius and ulnas.
Both are DCP, narrow DCP.
Yes, sir. DCP. 18 years female with osteochondrum of right femur, sir. These are the intraoperative pictures, sir. 3 centimeters and 3 into 2, sir. This is lateral, sir.
Picture circle. So the lateral distal part of the femur.
CT scan is done.
Very good.
So it's a potentially
Yes, sir. Pedant laterals.
Malignant transformation more common is peduncle or sessile?
Cell.
Extraperiosteal excision.
Next.
A 58 years male with intertrochanteric fracture of left femur, sir. We have done open reduction internal fixation with PFN, sir. Open reduction pattern, sir. Not close, sir. Open, sir. Raleigh, sir. This is a 26-year-old male with compound grade 2 middle third distal third junction shaft fracture of both bones of right leg, sir. We have done a close reduction internal fixation with interlocking nails, sir. This is valgus, sir. Not fixed. A 44-year female with 2 weeks old closed trimalleolar fracture of left ankle, sir. This is the CT picture, sir. Posterior fragment is big, sir. Approximately 40%.
Is articular involvement up to 40%? Small fragment is very, very important.
Big fragment, sir. Here we can see the posterior malleolus is a big fragment.
More than 40% is going to be more than 20%.
25%, sir.
40%.
There is articular combination of.
Yes, sir. So we have done open reduction with plating for left lateral malleolus and posterior malleolus, and open reduction with malleolar screw for left medial malleolus.
Joint is reduced.
Yes, sir.
These screws little. You have to get a mortise view.
Yes, sir.
That's not a mortise view. You see, you check they are not inside the joint.
Yes, sir. It's not inside joint. We checked.
Okay, difficult.
18 years old female with osteochondroma of right femur, sir. These are the intraoperative pictures, sir.
So what was done?
Excision of the osteochondroma.
Just excision or
Extra periosteal excision.
what is extraperiosteal excision? That is a short case.
Yes.
What is extraperiosteal excision? What does that mean?
We have to remove the periosteum along with the tumor itself.
So you take the periosteum along with the.
Yes.
What does it? Why do you have to do that?
To prevent.
You leave the periosteum, what happens? Keep the periosteum, excise under the periosteum, what happens?
May lead to recurrence, sir.
So what is osteochondroma?
It's a benign tumor of.
Krishna. Benign tumor.
It's a benign tumor.
What is it? How do you define? Your exam question. Short notes వస్తుంది. లేదా కానీ and if there will be one case osteochondroma. 50% of you will have to present. Yeah, what is it? So what is it? So what is it called?
Exhaustosis.
Is it a tumor or is it hematoma or what else? Is it a tumor, benign, or is it hematoma, or development?
It's a humorous condition, not exactly tumor, humorous condition.
So it's a normal bone growing in abnormal way. So what else is deficient with the bones? What is deficient here? What else is associated? Not that may not be understand. What else is associated with osteochondroma? There may be remodeling, failure of remodeling, or incomplete remodeling.
This is a 70-year-old female with 10 days old periprosthetic fracture of left femur, sir. We have done open reduction internal fixation with dual plating with bone grafting we have done, sir.
Yeah, okay. Any comments? What is it called?
Yes, sir. Periprosthetic.
Classification? No. So anybody? Classification. going to see more and more this. So what else you have to decide? Periprosthetic fracture around the hip or the knee? What do you want to know? Which will decide your management? Which will decide your management? I'm asking you, what is the important factor? So whether you can treat like this, or if you can't treat like this, what else you can do? Finally, so is it. Any senior residents? Pradeep is here? No. Yeah. Come sit in the front. Why these seats are vacant? All of you come in to sit in the front. You want to sleep in the back? Come sit in the front. So, what do you want to decide? Because you're going to see more and more of these.
Sir, you have to look for the status of the processes.
Mm-hmm.
If it is loose or intact.
Mm.
If it is loose, we can go for long stem.
So, you have to decide whether the joint is stable or unstable. If fracture is extending into the prosthesis, it will be unstable. So, that's important. If it is involving the prosthesis, it's loose. So, no point in fixing. You can't fix it. You have to revise it with an appropriate revision component. If it is not affecting the stability of the both hip and here, then you can fix it, treat like a primary fracture. Okay, go on. Okay, good. Next we will have general club. Who is presenting general club? Yeah, go on. This is online.
Yes.
You have to put it on the computer.
Yes, sir.
Huh?
Sorry, sir.
I know technology is developing, but you have to be ready. Where is it? You can talk about it. Go on, keep talking while that's.
Sir. Today's journal club, sir. Does the fracture morphology timing of intervention determine the outcome in an operated talus neck and body fracture, sir? This is a journal which has been taken from ankle and Journal of Ankle and Foot, sir, Asia Pacific. This has been conducted.
Who did you take anybody?
Sir?
Foot and ankle journal. Okay.
Yes, sir.
Whom did you contact?
Sridhar, sir.
Okay.
This journal has been conducted from 2015 to 2019, sir, on 49 patients, out of which 34 patients are talar neck fractures, sir, and 15 cases are talar body fractures, sir.
You don't have to say sir for every time.
Yes.
Present it. Go back. Yeah. You read this abstract.
Abstract. Background. Talus fractures comprise approximately 0.1 to 0.85% of all fractures. They usually present following high velocity trauma and with soft tissue damage. Our objectives are to study whether the fracture morphology, the timing of the intervention, injury status, and the presence of Hawkins sign influence the outcomes in an operated case with talus fractures. To test our hypothesis that open talus fractures, talus body fractures with comminution, and type delay in initiating treatment can cause poor results.
Okay.
So material methods, it's a retrospective analysis of all operated talus fractures between 2015 and 2019. Out of the total 62 patients, 49 patients met our inclusion criteria. Preoperative X-rays and preoperative computed tomography scans were analyzed. Based on the fracture morphology, cases were divided into Group A, talus neck fractures, and Group B, talus body fractures. Post-operative assessment of the fracture union, presence of Hawkins sign, and incidence of AVN, rate of infections, and secondary arthritis were noted. The functional outcomes were calculated using the American Orthopedic Foot and Ankle Society score. So the results are, among 49 patients, 34 talus neck fractures and 15 talus body fractures were assessed. The risk of AVN in talus neck fractures increases with the injury severity. There is no statistical difference between the closed and open talus fractures regarding the AVN infection rate and the secondary arthritis. The mean AOFAS score was 84.9 in group 1 and 81.8 in group 2. Hawkins sign showed 61.1% reliability for detecting AVN. However, the specificity is limited. So the conclusion is the talus neck and the body fractures outcome did not vary significantly. The incidence of AVN positively correlated with the increasing severity of the talus neck fractures. According to the Sneppen's fracture variance, the sagittal split type talus body fracture had marginally better outcome than a coronal split type and the crushing type body fracture with combination. The rates of infection and AVN between closed and open talus fractures and the initial time delay for surgery did not influence our final results, and there was no statistical difference.
Okay, do you understand what is keywords?
Yes.
What is it? What does it mean? Keywords is put in the bottom. Look at there.
Yes.
That one. What does it mean? Anybody? What is keyword? Key to open the lock. Keywords means when you search, put these words, this article will, you can see this article. Key means that's how you search for. Keywords for your name. If you're putting your Instagram, everything, you put keywords similar to that. You have Instagram. Did you put keywords?
Yes.
Yeah, similar to that. Okay.
So talus.
Leave the introduction. Go to material methods.
Sir.
Material methods straight.
Sir.
Okay, go on.
This is a retrospective study included 49 operated talus fractures between 2015 and 2019.
Single surgeon or
No, sir. Multiple surgeons. Sir.
Single center.
Single centers. Tertiary care hospitals. In patient aged between 18 to 75 years with more than 2 years of follow-up. Exclusions were complete extrusions, mangled feet, pathological fractures, and polytrauma, sir. Fractures were classified as group 1 and group 2. Group 1 consists of 34 talus neck fractures, which have been classified according to the Hawkins classification. Group 2 included 15 talus body fractures, sir, which have been classified according to the Sneppen's classification, sir. Outcome assessed included infection rates in open and closed, incidence of AVN, time to union, presence of Hawkins sign on follow-up imaging, functional outcome using the American Orthopedic Foot and Ankle Society score, sir.
Because foot and ankle is a recognized subspecialty in orthopedics, like orthoplasty, arthroscopy, and it's growing.
Yes.
Especially in India, it's very neglected,
Yes.
under-treated, under-diagnosed foot and ankle problems, especially in diabetics. Yesterday, Venu was there. He's the professor from King's College, London. He was operating in Apollo. He comes every 3 months, once in 3 months. So those who are interested, he was asking any of those who after passing PG, you want to do fellowship, you have to take an exam, you have to show that you are interested and you have knowledge. I can send you to be with him to do foot and ankle. Foot and ankle is growing specialty, subspecialty, and there's so much of work. Okay, go on. He comes once in 3 months, and operates on, of course, people. But I think it's a.
This is the Hawkins classification, sir. So we have a type 1, 2, 3, and 4. So type 1 is an undisplaced fracture, sir. Type 2 would be a subtalar joint dislocation. Type 3 would be a subtalar with an ankle joint dislocation, whereas type 4 would include all the 3 joints, subtalar, ankle, as well as the talonavicular joint, sir. This is the Sneppen's classification, sir. 1 would include the transchondral dome fractures, 2 would include the shear fractures, 3 would include the posterior tubercle fractures, and 4 would include the lateral process fractures, sir. And 5 is the crust fractures. So operative technique which was followed in this journal was group 1 included the 34 talar neck fractures.
Too much of material.
Okay, sir.
To reduce it. Okay, gone. You filled everything. Gone.
So closed fractures were operated once the swelling subsided. Open fractures underwent wound debridement within 6 hours followed by a screw fixation. Surgical approach, the approach which was taken was anteromedial approach under regional anesthesia. Two 1.8 mm K-wires used as joysticks for reduction under fluoroscopy. An anterolateral approach added for comminuted or intra-articular fractures. Loose fragments were excised and bone grafts used when needed. Joint instability managed with K-wire transfixation, and X-fix applied for high velocity injuries with soft tissue loss. Postoperative care, immobilization in a below knee plaster, non-weight bearing walking started immediately. At 6 weeks, range of movement exercises with partial weight bearing with pneumatic foot. At 12 to 16 weeks, full weight bearing was allowed after radiological union. So these are the
types.
types.
Okay, next one.
This is the second group, sir. Types.
Right, okay.
These are the patient demographics, sir.
Right. You have to read important points. Okay, go on. Go back.
So complications, avascular necrosis was seen in 45 patients of overall. Infections, total there were 5 cases. 4 were superficial, which resolved with antibiotics. 1 was deep, which required debridement, antibiotic beds, and later an ankle arthrodesis. So group 1, 4 infections, 3 were superficial, 1 was deep. So 17 out of the 34 patients had a radiological AVN, mostly asymptomatic. In group 2, 1 superficial infection. 7 out of the 15 cases developed AVN, sir. 1 required ankle and subtalar arthrodesis for secondary arthritis.
So quite significant.
Yes, sir. Yes.
The complication rate is quite high. 50% 45 means almost
yes, sir.
Every 1 in 2.
Yes, sir. So secondary procedures, 7 patients had to undergo, sir. 5 patients had undergone implant removals and 2 patients had undergone ankle arthrodesis. So AVN incidence increased significantly with higher Hawking grades. No significant difference in functional outcomes or complication rates between open and versus closed fractures, talus neck versus talus body fractures, though the neck fractures had slightly better mean AOFAS scores. A sagittal split talus body fracture had significantly better outcomes than other morphologies. Timing of the surgery did not significantly affect the AVN incidence. This is the most important thing, sir. Hawkins sign correlated inversely with the AVN. 61.1% of the patients showing the sign had no AVN on follow-up, sir. 2 years, sir. 2 years. 2 years, sir.
But you said timing of surgery did not significantly affect AVN. Do you accept the statement?
I will accept, sir. I will accept, sir.
But their time was immediate. Not like us. Not
Yes, sir.
months or weeks later.
Yes, sir.
Sometimes the talus is out in compound fracture.
Usually, talus fractures with ankle dislocations, it is there have been discussions that if the dislocation is reduced early, the risk of AVN of talus is reduced. But if there is no dislocation of the ankle or there is only a neck or a body fracture of the talus, no matter the timing of the surgery will not affect the AVN incidence, sir.
Only dislocated
Yes,
ankle.
dislocated.
What is Hawkins sign?
Hawkins sign is a lucent area in the subchondral bone of the dome of the talus, sir. It is usually seen after 6 to 8 weeks after surgery, sir. It will indicate revascularization of the talus, sir.
Hawkins sign is significant after 12 weeks.
Usually 6 to 8 weeks.
Is it significant after 12 weeks? No significance. Only after 6 to 8 weeks. Beyond 12 weeks, no significance. That is important point of all.
Ganga, they have a protocol.
Mm.
The moment a patient lands in casualty
Right.
with a open fracture, the patient should be in the OT within 45 minutes.
45 minutes. Irrespective of the time.
Casualty to OT.
I think that's a very good protocol.
Teamwork. Irrespective of the time of the day or night.
Mm.
Any open injury, sir, first, when
Mm.
automatically is indicated to the anesthetist.
Mm.
They quickly shift them to fourth floor
Mm.
where they're given regional blocks.
He worked in Ganga.
So within that process, all the vitals, all the routines are sent, and by the time the block is given, the routines reports are ready inside the operation theater.
I think we should have something like that. May not be 45 minutes, but maybe
Anything should be less than 6 hours.
6 hours.
Interval should be much lesser. That's the objective.
So shall we make less than 6 hours?
Yes, sir.
Lakshmikant, make a protocol. Go on.
It is operated early in the morning, 9 o'clock. The case comes at night. Our setup, I think we have to.
But I think you see, no point in operating between midnight 12 o'clock to 6 o'clock. If comes at 12, operate at 6, 6:30. Oh. So 12 to 6, no such, but up to 12 o'clock, after 6 o'clock. Okay. Make a policy like that.
Discussion. Hawkins sign, while a reliable predictor of avian, has got low specificity. In our study, 18 patients had a positive sign, but only 11 showed no avian, sir. Avian incidence is higher, higher the fracture severity, higher is the avian risk. Delayed surgery did not affect the outcomes. Incision rates were similar between infection rates were similar between open and closed fractures, sir. Post-traumatic arthritis was seen in 41% in both groups. Avian and arthritis remain common despite proper fixation. Conservative treatment is advised for mild arthritis. Arthrodesis only for severe or non-responsive cases. Only a few patients in the study needed a fusion surgery, that is a tibiotalo-calcaneal nail, sir. Conclusion, avian incidence increased with talus neck fracture severity. A sagittal split talus body fractures had better outcomes. Open versus closed fractures showed no significant difference in avian or the infection rates. Surgical delay did not affect the complication rates or the functional outcomes, sir.
Post-traumatic arthritis was seen in 41% of both groups.
Yes, sir.
What is Zip and Ramlet classification?
What is it, UJ?
Yeah. Zip and Ramlet is for post-traumatic deformities and arthritis. Zip and Ramlet with malunion with subluxation of the, with or without subluxation. Malunion with or without subluxation of the joint. Type 1. Type 2, non-union with subluxation of the joint. Type 3, 1 and 2 plus partial avian. Type 4, 1 and 2 with complete avian. Type 5, 1 and 2 with aseptic avian. What do you mean by aseptic avian? Septic avians.
Infection.
Yeah, severe infections. So are all gone. So that is called Zip and Ramlet classification. That's very, very important. You said 41%, irrespective of the both groups. That point is very important. We have to talk in terms of Zip and Ramlet classification.
Very good. So he reads very well. He prepared before coming and attends all the conferences. Important. So I think first year, did we allot thesis? Not yet. So next week we will discuss about thesis. So probably you can think about topics. First year. No. Because you have to submit your thesis topic. So think about foot and ankle as well. So you choose a thesis topic with some subspecialty interest. So you choose in different subspecialties. And so many subspecialties are in orthopedics. Shoulder, upper limb shoulder, spine, what is the orthoplasty, hip, knee, pediatrics, foot and ankle. What else is there? So trauma of course main.
Yes.
So those who are interested, so it should have some impact on your future career. Okay, good. But you had too much of material.
Okay, sir. I'll reduce it, sir.
And we said no beards in orthopedics.
Okay, sir.
They don't go well. The common cause of infection is fall of hair into the wound.
Yes, sir.
Okay, good.
Thank you, sir.
Yeah, that's every time you're saying, but nobody is preparing the critic. Last slide should be critic. I said the title, whether appropriate for the study and everything, all the results, material, methods.
So it would have been a good study if they have done a prospective case series, because it's a 4-year study with 2-year follow-up and they have presented after 6 years of follow-up. The second is that the common thinking that we think that open fractures have poor prognosis and will go into arthritis, that they are defining that open closed, there is no significant difference.
Yes, sir.
Because talus fractures, the rate of soft tissue injury is much higher.
Yes, sir.
And so if you imagine like why the sagittal split talus body fractures have better outcomes. So if you go back into the anatomy and the blood supply of talus, which has a retrograde supply, if there is a sagittal split, still there is supply for both fragments. So they have better outcomes.
Yes.
So that you have to imagine that introspect that this fracture, because of this pattern, is having better outcomes.
Yes.
Instead of the other neck fractures which are having poor outcomes. Okay.
Coronal fracture will have poor outcome compared to sagittal.
Yes.
And what we think is like talus structure, we wait for the soft tissue to heal, then maybe avian chances increase. So they are saying that even if you delay the surgery, it's not affecting any chances of increase in avian. That's
Yes.
another added point that you can.
Yes.
So this should affect your practice, because last week you had a comminuted talus fracture.
Yes,
That's why you're presenting this. No?
Yes.
And another point is, when you talk about open versus closed, open fractures are high velocity injuries, closed fracture low velocity.
Yes.
And other thing is with contamination, without contamination, with combination, without combination. All fracture pattern morphology also plays a good role.
Yes.
We have to take care.
Foot and ankle, I think, very
That's what we are
neglected.
heading. Show the title.
Neglected.
Show the
We don't treat them well.
Show the title.
Title.
Ill understood, because we only treat well which we know well.
That's the
If we
fracture.
don't know well, then we won't.
Timing of intervention, determine the outcome.
Very good.
Thank you, sir.
So next week, General Club, today only we'll decide.
We shall.
And this, I think the good thing about open fractures, we will appoint Lakshmikant as a coordinator, irrespective of the unit. Every open, I think we make a WhatsApp group. So any open fracture, we'll put in the WhatsApp group and should inform Lakshmikant, irrespective unit. You coordinate with the unit, we'll see. And our aim is to get to the OT within 6 hours. Everybody understood?
Yes, sir.
We form a group with all the PGs and all the stuff, so that we'll know. And anesthetic, sir. Because new Hariprasad Reddy is coming.
Coming back.
Yeah, he's joining this Saturday as HOD, probably medical super. Probably he will have more good anesthesia, probably improved anesthesia facilities.
VSI in that one,
And this is the third time, went out and coming back. Sorry, I told you we cannot go, cannot leave again. Done? So next week, we will have your fully, some of you can discuss today and show me the afternoon. Interesting topic. Today go to the library, not now, but after once you finish work and find out, your seniors will guide you how to look for a